Welcome to our second series of webinars on the Canadian Adult Obesity Clinical Practice Guidelines, hosted by the Office of Lifelong Learning and Obesity Canada. My name is Denise Campbell-Scherer, and I'm the Associate Dean for the Office of Lifelong Learning, as well as a Professor of Family Medicine here at the University of Alberta. It was my great pleasure to serve on the executive of the Canadian Clinical Practice Guidelines. The new clinical practice guidelines are expansive, 19 chapters on a wide range of topics related to obesity diagnosis and management, weight bias, and more, all written by Canada's top researchers, health practitioners, and patient advisors. They're the first truly patient-centered clinical practice guidelines on obesity and the result of more than 3 years of hard work. Just before we begin, I'd like to go over some items. We acknowledge that we are on traditional territories in Alberta of the many First Nations, Métis, and Inuit, whose footsteps have marked these lands for centuries. If you have any questions pertaining to technical difficulties or L3 programs and services, please use the chat feature of the webinar located in the middle bar of the bottom of your screen. If you have a question for our panelists, please use the Q&A feature of the webinar. Our panelists will answer several questions following the oral presentation. Some questions will be responded to through text in the Q&A window. You can, at any point, use the Q&A button at the bottom of your screen to submit questions. We anticipate many questions. Please review what has already been asked and upvote those questions you would like to have answered. We cannot guarantee that the panelists will be able to respond to all of your questions. A recording of the webinar will be available next week. It will be sent via email to all those that registered. This link is for your personal use and is not to be forwarded or shared. This activity has not been formally reviewed by the CFPC or Royal College. However, it is eligible for non-certified credit. Main Pro Plus participants may also earn additional certified credits by completing a linking learning exercise. It is my great pleasure to introduce Ms. Jennifer Brown, who will be presenting on the medical nutrition therapy and obesity management. Ms. Brown is a registered dietitian and certified bariatric educator with the Ottawa Hospital Bariatric Center of Excellence. She specializes in bariatric nutrition, micronutrient deficiencies, appetite regulation, and the pathophysiology of weight change while using a non-dieting approach to support individuals before and after bariatric surgery. Jennifer is a steering committee member and lead author on the 2020 Canadian Obesity CPGs, chair and executive member of USA and Canadian dietetics groups, and a national representative for the Canadian Obesity Advocacy Network. Jennifer has been an invited speaker at national and international conferences and an author of a number of publications. She's passionate about changing the professional education and healthcare system's approach to obesity by focusing on health and quality of life instead of weight and body size ideals. Welcome, Jennifer.
All right. Well, thank you very much, Denise, for that warm introduction. And thank you, everybody, for joining us today for the webinar on medical nutrition therapy. Before we begin, I would like to acknowledge my co-authors on this chapter. This could not have been done without the tremendous amount of dedication and hard work from registered dietitian Carol Clark, registered dietitian Carlene Johnson-Straclosa from Alberta Health Services, and Dr. John Stephen Piper from the Faculty of Medicine at the University of Toronto. So as we kind of go through today's talk, I want to preface by just doing a quick review of the methods that were used within the clinical practice guidelines and as well as the medical nutrition therapy chapter. We'll go into the definitions and terminology changes, and the rationale for this is the nutrition chapter used some definitions and terminology to preface some of the updated evidence. So we'll review some of those changes, talk about the recommendations and key messages for providers and people living with obesity, the clinical nutrition implications themselves, as well as limitations and opportunities for future directions. So the methodology itself, this has been reviewed in other webinars, but just as a brief reminder, the clinical practice guideline process was a very rigorous process. The executive committee was made up of members from Obesity Canada, as well as the Canadian Association of Bariatric Physicians and Surgeons. There was a steering committee made up of 17 or 16 steering committee members that made up of patients, clinicians, obesity researchers, and methodologist experts. And the chapters themselves, we had over 60 authors and reviewers that range from researchers and clinicians, as well as patients and primary care providers. The overall vision of the CPG process was to develop a non-biased, scientifically valid, and trustworthy set of clinical practice guidelines with specific recommendations for the management of obesity to help inform decision-making that's patient-centered and supports that shared decision-making process in order to optimize patient care. The target audience for these guidelines were primarily for primary care providers, either working in solo practices or in multidisciplinary teams, as well as for individuals living with obesity and for policymakers. So to jump on that as well, the medical nutrition therapy chapter was written with the context of evidence for primary care providers. It may not be as applicable for specialties such as registered dietitians who have a much more specialized training in nutrition. So these provide an overarching view, but again, they do not replace the expertise of a dietitian. The development of the clinical practice guidelines themselves, the timeline is quite extensive, dating back to December 2017, and in publication of the final product in August 2020. I'm not going to spend a lot of time on this timeline. This is something that has been discussed in previous webinars. But just as the process itself, this was the same for our chapter of the nutrition, nutrition guidelines. So we created 25 questions, or we generated 25 questions using the PICO format. And we had librarians and research leads from MRST, which is the McMaster Evidence Review and Synthesis team, to help provide assistance. The actual search itself was conducted using Medline and the M-based databases from January 2006 to June 2018. It generated over 16,000 articles that was used in what's called the Distiller SR software, where we looked for eligibility. We did full text review of over 700 papers, and we did analysis and worksheets for the methodology and rigor of the studies for over 160 papers, which is what generated our recommendations. We used the grade format to grade or rate the level of evidence as well as the strength of the recommendations. This was a very transparent framework and a systematic approach, and was also conducted or reviewed by the MRST team. The literature review for our nutrition chapter generated 7 main evidence-based recommendations. This actually turned out to be more like 20 recommendations, but we compressed them to within 7 main recommendations. And they range from the highest level of evidence based on the research itself at the time. So that included medical nutrition therapy delivered by a registered dietitian, looking at specific dietary and food-based approaches, and intensive lifestyle interventions. And this is the first set of guidelines that actually include non-dieting approaches, which is an umbrella of different types of literature approaches that use non-weight focused or non-dieting approaches in terms of nutrition outcomes. The actual process itself, I just want to emphasize the rigor that goes into the engagement and the whole review process itself, from the end users being patients, primary care providers, and having input from both the steering committee, the primary care providers, patients from the public engagement committee. The research questions themselves, again, were very much in line with the needs coming from people living with obesity and the Indigenous community members that brought forward the questions that helped to generate these guidelines. And then the review process itself was quite extensive, including input and feedback and review from people living with obesity, primary care providers, the internal expert review of the steering committee, the MRST review, so independently looking at it from a methodology standpoint, from the librarians and the expert methodologists, as well as an expert peer review panel. Funding for the guidelines was primarily done through CIHR, Obesity Canada's Focus Initiative, the Canadian Association of Bariatric Physicians and Surgeons, and in-kind support from scientific and professional volunteers engaged in the process. And I can't emphasize enough, I think, the importance about the mitigating conflict of interest that was conducted throughout the whole process of these guidelines. We had a conflict of interest policy from the very beginning. This was managed by the executive committee. All authors, steering committee members, executive committee members had to fill out international committee and medical journal editors forms that helped to mitigate any conflict. The other key important thing is that this was on a 100% volunteer basis. So all of the authors, everybody involved with the executive committee, steering committee, there was no remuneration in terms of anything within these guidelines. And lastly, it was independently reviewed by methodologists from the MRST team, as well as external peer review. So that brings us to kind of some of the changes in terms of definitions and terms that are used within the nutrition chapter. And as previously mentioned from other webinars, obesity is being redefined. So instead of using BMI at an individual level, we're focusing on defining obesity characterized by adiposity that impairs health. And I think it's important for us to recognize that the recommendations and the key messages in the guidelines, specifically in this nutrition chapter, are specific for people living with obesity under the new definition and may not be applicable or appropriate for people who are living in a larger body. The other term that's very different in these guidelines or in our chapter is the term obesity management. So in obesity management, we're referring to health-related improvements, not specifically weight loss. So if weight loss occurred as a result of an obesity intervention, it shouldn't be the focus or the outcome marker that we're looking at. It should be focused on health and quality of life improvements. So if weight loss occurs, that could be good or bad depending on what the client's needs are. But I think the ultimate goal is improving their health and quality of life through obesity management that may or may not be weight or weight focused. So the medical nutrition therapy, or MNT, is possibly new for some people in terms of terminology, but this is an evidence-based approach that we use in what's called nutrition care process. It's typically used by registered dietitians in both clinical or community settings, and it focuses on nutrition assessment, nutrition diagnosis, nutrition therapy or counseling, and evaluation and monitoring. And again, this has been used in research for many years as well as clinical practice. So we ended up using medical nutrition therapy as it reflects evidence-based approaches. The other change that we see in terminology is instead of using the word diet, we have used the word nutrition interventions. And we use this because it refers to more evidence-based nutrition approaches that improves health outcomes rather than the word diet that tends to have much more of a weight loss focus and is very much geared around the cultural acceptance of dieting for the goal of weight, whereas we're looking at nutrition interventions as a form of all health factors, including cardiometabolic improvements or other quality of life factors. So the actual recommendations and key messages themselves, when we looked at the nutrition interventions in the literature, they vary. And again, traditionally, the research that's been done has primarily been done in caloric restriction, looking at macronutrient-based approaches, dietary pattern approaches, food-based approaches, intensive lifestyle interventions, medical nutrition therapy provided by a registered dietitian, and new to these set of guidelines is what's called non-dieting approaches. So I'm not going to go through all 7 or 20 of the graded recommendations. These are at your reference, available on Obesity Canada and the Canadian Association of Bariatric Physicians and Surgeons website. So I would encourage you to visit the websites to review the actual graded recommendations. But I do want to give you some key messages that you can use in practice. And the first key message is that healthy eating is important for everybody. Regardless of what someone's body size, weight, or health status is, I think we need to be very cautious when it comes to nutrition and quote unquote healthy eating messages, because everybody, regardless of body size, weight, or health condition, has the right to having access to food. We also want to encourage the use of evidence-based nutrition resources that can help be aligned with patients' and clients' values, their preferences, and more importantly, their social determinants of health. So really doing a thorough assessment to determine what type of nutrition resources could be appropriate for them. The second main message is that there is no one-size-fits-all eating pattern. I think adults living with obesity may consider a variety of different nutrition interventions that can be client-centered, they can be flexible. And what we see in the evidence is that long-term adherence, or whatever someone can follow long-term, is ideally what's going to work for them. However, it's important to individualize that to your client or patient based on life cycle changes, social determinants of health, preferences, and whatnot. The third main message is that nutrition intervention should really focus on health outcomes for reducing any type of conditions and improving quality of life. So table 2 in the chapter reviews some health indicators that clients or patients may come to you wanting to lose a certain amount of weight. And we need to try to redirect those goals on what are some of those health related outcomes of that weight change that they're trying to aim for. Is it that they're wanting to have more energy or have maybe less hunger or less cravings? What nutrition interventions could we be looking at that could help change those goals that they have in mind? And then having clients actually monitor those on either using a rating scale from 0 to 10 or using a visual analog scale where again you get a measurement from the client on their perceived outcome of that goal. So for example, someone might give you an energy level of 2 out of 10, 2 being low, and so monitoring those changes with that nutrition intervention, could we get them up to a 5 out of 10 or an 8 out of 10? And that's going to help facilitate that efficacy that patients are looking for rather than numbers on scales. Key message number 4 is really looking at nutrition interventions that focus on individualized eating patterns, food quality, as well as building healthy relationships with food. So having mindfulness-based eating practices help to reduce food cravings, help to reduce that reward-driven kind of eating patterns if some folks are struggling with that area, improving body satisfaction, as well as improving awareness of hunger and satiety cues. Message number 5 really emphasizes the importance that calorie restriction, even though it can result in short-term weight loss, it's not typically sustainable long-term. And we know through the biology and physiology of weight reduction that calorie restriction can cause neurobiological pathways to change to control appetite, hunger, cravings. Ultimately, our body weight is regulated by our brain. This has been discussed in another webinar on the science of obesity, but it's important for us as clinicians to recognize that calorie restriction, although it can cause short-term weight loss, it may have long-term effects on the neurobiological pathways that control appetite and weight. Message number 6 is really around people living with obesity may have an increased risk for micronutrient deficiencies, especially for vitamin D, vitamin B12, and iron deficiencies. We know that restrictive eating patterns and obesity treatments that have used medications or bariatric surgery may also increase someone's risk for micronutrient deficiencies and possibly malnutrition. So having a baseline assessment by measuring biochemical values, doing an evaluation of food intake, food preferences, vitamin and mineral supplementation, and any drug or nutrient interactions. So again, really looking at the risk of malnutrition is important. And this is where it leads us to message 7, which is around collaborating with a registered dietitian who has experience in obesity management and medical nutrition therapy. Number 8 is really focused on the future direction for research in nutrition. We want to emphasize the role of focusing on nutrition outcomes around health behaviors, not specifically on weight loss or body composition outcomes. They're still important, but I think it's mindful for us to look at the health-related outcomes and cardiometabolic outcomes that nutrition interventions can really support. We also want to encourage future research in nutrition to use the updated definition of obesity rather than exclusively using BMI to categorize people living with obesity. So again, using the updated recommendation or updated definition where adipose tissue impairs health. And lastly, we need more qualitative data that looks at the lived experiences of people living with obesity. Because again, research needs to be driven and geared with a patient-centered approach. And that leaves us to some key messages for people living with obesity. Number 1, or the most important thing, is again that nutrition is important for everyone, regardless of size or health. Health is not measured on a scale. So when someone is ready, or when you're ready to make any changes, choose behavior-related goals that help to improve your nutrition status and your health. And that health could look different from person to person. It could be your medical health, your functional health, your emotional health. It may not have anything to do with the number on the scale. Remember that there's no one size fits all when it comes to healthy eating patterns, that you want to choose an eating pattern that works best for you, for your health, for your goals, and something that you can follow long-term rather than short-term. And talk to your healthcare provider about the advantages and disadvantages of all the different nutrition approaches. How you eat is just as important as how much you eat. So practicing that mindfulness and promoting that healthy relationship with food and eating is important. We want to de-emphasize dieting. In fact, we want to try to eliminate dieting entirely. We need to recognize that when restricting calories or dieting mentality, that this can cause the body to defend against that weight loss, and over time can increase both biological and physiological appetite measures as well as weight. And ask to see a registered dietitian to help individualize that nutrition for your needs. Which leaves us to the clinical nutrition implications. So what can we do as clinicians in terms of applying this in practice? So if you haven't already read the chapter, you'll see it's a very extensive chapter. And we thought it would be useful to summarize some of the clinical outcomes of all the different nutrition interventions. So the table that you see on the right of the screen kind of gives you an outline of all the different nutrition interventions and what health and quality of life impairments we might see. And so table number 1 then goes into a lot more detail about the specific outcomes that you might see, including the advantages and disadvantages seen in all those interventions. So an example could be something like, if a client comes to you with the goal that they're wanting to reduce their cholesterol levels or their blood sugars, and you could take a look at all the different nutrition interventions that has evidence to support those health outcomes. Then using that type of process, we want to use an informed consent process with clients to then review what would the health and quality of life outcomes be, what potentially weight changes might occur if that's something that they're coming to you with a goal. And then more importantly is what advantages and disadvantages do these different nutrition interventions have. That way clients can make an informed consent. And it also helps align that redirection to be more health and quality of life focused rather than weight loss or weight goal focused. So one of the ways that I can kind of contextualize the medical nutrition therapy is looking at this from an adjunct therapy approach. For example, In the old guidelines, we very much looked at nutrition and physical activity as a foundation before adding in any other therapies. In the new guidelines, one of the ways we can look at medical nutrition therapy and physical activity is kind of as the core foundation of all these other interventions. So medical nutrition therapy can be used as an adjunct therapy to psychological interventions, pharmacological interventions, and surgical interventions. And so the actual nutrition approach might differ depending on which one of these approaches the patient and client decides. And it could also be adjunctive to each other. So they're not done in their own silos. They could be done concurrently with other interventions. But it is important for us to have that informed consent with clients, because there are going to be times where acute weight loss may actually be beneficial for some clients. And I'm mindful of this because working in acute care, especially in a hospital setting, when we think about other acute interventions like nutrition that we would use for chronic kidney failure or diabetes management, or I'm reminded of where if we were requiring to use enteral or parenteral nutrition for someone with, an ischemic bowel, for example, recognizing that there are potential times where acute weight loss may be indicated for clients. And it's important for us to not only try to mitigate those risks, but to try to best meet the nutrition needs of a client if acute weight loss is indicated. It is important, though, that individuals recognize or are known that there are potential consequences of that weight loss, including metabolic and appetite changes, and that we need to recognize too that there's a higher risk of malnutrition and sarcopenic obesity. So just recognizing that nutrition interventions with acute weight loss may cause those conditions to worsen. So other conditions we want to be mindful of is micronutrient deficiencies, that there is an increased risk with the history of restrictive eating patterns, as mentioned, medications and bariatric surgery, drug and nutrient interactions. So this is why it's important to do an assessment using biochemical values, looking at vitamin D, B12, iron. There could be more biochemical markers you would look at, but these are what's indicated in the literature. Looking at malnutrition, again, I think this has been something we need to spend a lot more time looking at. Unfortunately, many patients and clients who are living with obesity may have practiced in very restrictive type of eating patterns in the past, and that could cause an inadequate nutrition status. So we see this in the literature amongst patients and clients who are looking for bariatric surgery. So making sure that there's an actual an evaluation done by a registered dietitian to help assess for malnutrition. And also recognize that disordered eating patterns, the current evidence shows mixed results. The current evidence does not show a causation where with obesity management or in weight loss interventions that cause eating disorders. But we need to be mindful that eating disorders and disordered eating patterns tends to be underdiagnosed and untreated. So if you suspect any type of symptoms associated with eating disorders, consider referring to a mental health specialist or eating disorder programs for further assessment. And this leads us to the limitations and opportunities for future directions. So as with any research, there's going to be limitations, and with a clinical practice guideline to the extent that the 2020 guidelines proposed, our nutrition chapter found that one of the largest limitations was the fact that the evidence we were reviewing was very weight loss focused, and that the participants in terms of samples was primarily using BMI to define obesity, which again goes in line with the highest level of evidence that we have at the time. But moving forward, recognizing that the definition of obesity needs to move beyond BMI at an individual level. We also recognize that much of the evidence we were reviewing did not include some of the confounding factors that we may see with people living with obesity, such as health inequalities, social determinants of health. There was a lack of diversity in many of the research papers we reviewed. A lot of research done in nutrition may not include a baseline nutrition assessment. And a lot of the studies, most of the studies are short and medium term in terms of interventions, with a few longer term. But these are all limitations that do pose challenges when we're looking at this from a clinical guideline perspective. So the future direction itself and some of the opportunities for us to improve in research. We propose that we need to have a development of assessment tools that use the new definition of obesity. So again, looking at adipose tissue where it impairs health, we need to have objective measures to understand when adipose tissue is impairing health. And this will help guide much more that personalized nutrition. So we know that the role of nutrigenomics can play a great role in terms of that personalized nutrition. So we emphasize the role that direction can have. We also recognize that research and patient care should really focus on the relationship of food, food security, internalized weight bias, stigma, discrimination, people's previous and current eating behaviors, and their social determinants of health can all play a huge factor in confounding research. So we want that to be explored further, including the patient and client voice. Again, emphasizing the motion around nothing about us without us, and really bringing in the patient voice. Having assessment of nutrition status at the baseline of research, again, looking at social determinants of health, diversity, social and health inequalities, and how these may play factors possibly in someone's health conditions. So to summarize and leave you with some key messages, remembering that nutrition, there is no one size fits all when it comes to eating patterns, that nutrition interventions should really be individualized. We want to focus on health outcomes regardless of weight change, that understanding that caloric restriction, although it can lead to short-term weight loss, it may cause biological pathways to defend against that weight loss. So clients and providers need to be aware of that. Medical nutrition therapy is essential independently, but also in adjunctive therapy with other interventions. And that's where the role of referring to a registered dietitian can be so useful and helpful. So with that, I want to also leave you with the fact that the guidelines themselves are a living document, meaning that they will undergo regular updates. As we know in nutrition, these change day to day, if not minute to minute. So emphasizing the fact that we will be updating the medical nutrition therapy guidelines as the evidence emerges. So with that, I would like to thank you for your time, and I'm happy to answer any questions.
Well, thank you so much, Jennifer. So I just want to remind all the colleagues that if you have questions, there's a Q&A box on the bottom bar and the black bar on the right-hand side. And if you can please type your questions in there, as we do with these webinars, we will be able to work through those. So joining us on the panel today, we have Carol Clark and Carleen Johnson-Stoklosa and Dr. Arya Sharma. So Carol Clark is a registered dietitian in Ontario with expertise in many areas of nutrition, working in hospitals, primary care, and private practice since 1995. She has a special interest in cardiovascular health, obesity, and healthy aging. With a master's of health science in nutrition and communication, her goal is to help people improve their nutritional health by adopting eating patterns proven to prevent and improve chronic diseases. Currently, Carol provides nutrition consulting services for group programs, writing, program development, and presentations. She's the past co-chair in the Diabetes, Obesity, and Cardiovascular Network of Dietitians of Canada. And Carleen is a registered dietitian and nutrition team lead with chronic disease management for the Edmonton Zone with Alberta Health Services. She has over 20 years experience as a clinician, with most of her experience in ambulatory specialty care. She holds a BA Psychology Diploma in Health Promotion and Education, a BSc in Dietetics, and a master's degree in Nutrition and Metabolism, focusing on sarcopenic obesity. Carleen has collaborated on several peer-reviewed papers, book chapters, and clinical guidelines, and most recently a proud co-author for the 2020 Canadian Clinical Practice Guidelines for Adult Obesity on the Medical Nutrition Therapy chapter. After work, you'll likely find Carlene researching her next trip someday, or sorting out her travel photos from her latest adventure, which was Spain and Africa in 2019. Sounds awesome, Carlene. And Dr. Arya Sharma is a professor and chair of obesity research and management at the University of Alberta, where he's also the medical co-director of Alberta Health Services Provincial Obesity Program. In 2005, he spearheaded the launch of the Canadian Obesity Network, now Obesity Canada, which has remarkably transformed the landscape of obesity research and management in Canada. His research focuses on an evidence-based approach to managing patients living with obesity and includes the development of the Edmonton Obesity Staging System. So welcome to the whole panel. And it looks like we've got some good questions to kick us off. So Darlene asks, what does medical nutrition therapy consist of compared to other nutritional strategies? So who on our team of panelists wants to tackle that new lingo?
Well, I'm happy to take that one. And this is Jennifer speaking. So if Carol or Carlene wants to add on to it, please do so. Medical nutrition therapy is typically a chronic disease management approach that's used by registered dietitians. It's a part of what we call nutrition, the nutrition care process. So it's within our scope of practice to offer chronic disease management, counseling, lifestyle interventions. And the MNT, or medical nutrition therapy, uses nutrition interventions that has evidence to support it. So it includes a nutrition assessment, nutrition diagnosis. So as dietitians, we have international terminology that's been standardized across the world, and so all dietitians use this language. And so we have evidence that can help support which nutrition interventions can be used for different chronic diseases or different health conditions, or even just the counseling and education for clients and for patients. So anything I missed, Carol or Carlene, feel free to jump.
I think that was an excellent explanation, Jen. It's Carlene here. Again, I think it helps to differentiate when you're actually doing like an intentional therapy versus providing maybe just kind of general advice, that we're actually looking to achieve a clinical outcome with that specific therapy, not dissimilar to where you would for like a physical exercise prescription or a medical medication dosing or prescription as well.
So it's Ari here. So if I can just chip in, I mean, from my perspective, I think both of you have, both you, Jennifer and Carlene, you've said it quite well, that when we talk about this, what we actually mean to show is that we're talking about a treatment. So therapy is treatment. And this differentiates it from just, general healthy living or healthy eating recommendations. You're trying to achieve a clinical goal here, and this is the treatment path to achieve that. And so it is, as you said, it's actually an intervention and a treatment path. And that makes it different from simply saying, this is a healthy diet, or this is just a diet which is focused on one parameter, like, simply weight loss. Because, again, as Jennifer pointed out, obesity management is less about weight loss. It's more about health gain, or in fact, it's not about weight loss at all. It should be about health gain. And that may require very, very specific nutrition recommendations based on the individual's profile. And so I think this differentiates it very much from the general, notion that, well, all you have to do is eat healthy and you'll be fine. We're actually talking about treatment here.
Yeah, and Aria, you bring up a really good point. I loved how you were saying like the difference between an intervention versus just healthy eating messages, and something that we really wanted to emphasize with the evidence that we reviewed, and just also in clinical practice, is every single person, regardless of what someone's weight, size, health condition, what their background is, everybody should eat well and eat foods that they enjoy and that are in line with their cultural preferences and access to food and whatnot. And so I think it's important that we try to put food or eating into a category as healthy eating only for improving quote unquote weight, when really it doesn't matter what your weight is. Everybody should be eating well and fueling their body in a way that that is respectful and good for their health. So I think that's why we differentiated between just nutrition messages that's right for everybody versus those nutrition interventions that can be used for obesity management.
Super rich answers. Excellent. So Stephanie has a really interesting detailed question here. So just regarding the recommendation around caloric restriction that can help achieve short-term reductions in weight, i.e. less than 12 months, but where we don't have that longer-term evidence, and that it can affect neurobiological pathways, et cetera. In your practice, if you have a client that's eating above their caloric needs, would I obviously would all recommend a decrease in calories, but can you talk a little bit about in your practices how you may have observed some of these impacts, and seeing how different cases may have evolved with regards to the impact on people's experiences around hunger and cravings, et cetera, and weight regulation? Maybe Carol, we'll go to you first, just to get your perspectives in on this.
Well, I don't know if I'm actually the best person to answer this question because I'm not actually doing individual clinical practice right now. So I think maybe Carleen or Jennifer would be better able to answer that.
Oh, sure. Thanks.
Yeah, I mean, I can go first. I think a lot of times if I have clients who might be having, calories above their so what's driving them to have higher caloric intake, and are they experiencing hunger, are they experiencing cravings, are they getting a sense of fullness, why are they or not, and so I might look at more of a food approach, looking at meal timing, meal balance, the nutrient breakdown of the food itself. I don't know if I would be solely focused on the calories. I mean, as a dietitian, I would be doing that behind the scenes, but it may not be a goal or something that I would want the client to be particularly focused on, but it does depend on that client, because sometimes that would be something that they're really wanting to focus on and it doesn't cause any harm. And so we would use that. So it really depends on the client.
Excellent. Thanks, Jen. Aria, Carleen, did you want to weigh in on this question? It's so multifaceted.
Well, Aria here, it's a very important question, because the question is really about someone who's eating too many calories. And the question then is, well, how do you define too many? By definition, too many would imply that the patient is, or that the person is actually in excess caloric balance, which means that there's more calories going in than going out, which means that this is a person who's actively gaining weight. And they're obviously that would be the consequence of being on a diet that contains more calories than you need, means you're going to be gaining weight on that diet. And so ultimately the goal here is going to be to, reduce the caloric intake to a level which would help the patient, maintain their body weight, which is, which then means you have to address all the factors that Jennifer talked about, right? I mean, the context of eating, etc. And the changes, the hormonal changes that serve to defend the body against weight loss, so this is what was referred to here as neuroplasticity, etc. Those generally don't kick in until you create a caloric deficit. So if you're only trying to go from excess calories to, the calories that you need to require to maintain your current weight, you are not going to see those. You're not going to see those mechanisms kick in. Those mechanisms generally kick in once you start going into negative caloric balance, which then means, that under that condition, you would be eating fewer calories than you actually need to maintain your body weight. So I hope that's clear, that that it depends on where you're coming from. If you're coming from excess calories versus, a obese stable person who's eating the exact right amount of calories that they need to maintain their current weight.
Mm-hmm. And I guess the other message that we might want to reemphasize from the other webinars is then again, if someone's not in weight balance all of a sudden, what other root causes could be going on here that could be contributing to it? So has something changed? Are they on a different medication? Have they, that's more obesogenic? Have they, developed some other sort of intercurrent illness issue that's affecting their root causes? So if we think of the 4 M's in the assessment chapter, just to keep it in
Right.
context with the whole story. Yeah. Anybody else have any other thoughts on that? Jen, did you want to chime in on that at all? Or Carly, are we good with Stephanie's question? Stephanie, are we good with your question? Okay, maybe we'll go on to Mary Lynn then. So Mary Lynn's wondering about whether any of you have tips on how to convince clients that weight loss isn't the goal, but health gain. So, you know, I think we always call that the expectation gap, and there's definitely grief associated with that sometimes. But can people comment on sort of that shift for people?
Well, I mean, this is an area that's near and dear to me, just because I've also struggled with, you know, over the years trying to, you know, how do we shift that weight and weight loss focus, and that, you know, our society is very driven by weight loss goals. So how do we shift that to be more health focused? And I have found that by actually teaching and educating patients about the science of weight regulation and appetite and what's actually happening in our bodies when someone loses weight or gains weight, having that understanding that it's not something that they've done to themselves, that it helps to reduce that stigma and that blame and shame that people often feel. It allows people to be able to step back and then recognize, okay, you know, what are my weight loss goals? What are they, you know, really driven by? So I will use I often will use the analogy of a iceberg, and on the surface of it, they say weight loss is the goal, but underneath it, we often will say, okay, why do you want to have weight loss? And I often get people to fill in kind of underneath that surface as, oh, I want to be able to have better mobility, or want to have less knee pain, or play with my kids or grandkids. I want to live longer, or be able to do better self-care, have more energy. And so all of a sudden we're now like pulling out some of those health behaviors that we can now focus on. And whether it means that there's some nutrition interventions we could do to help that, or if it means connecting with another healthcare provider, referring to another specialist to help with some of those other areas. Now, all of a sudden, we're getting to some of the behaviors that people can manage, rather than them constantly just focusing on that weight itself. And so, again, the education, the understanding, trying to bring back people's self-efficacy and stop that shame and blame, and then start to focus on some of those health behaviors. That's something that I've found that's worked in practice, and I've been finding it working very well.
Super. Thanks, Jennifer. Anybody else on the panel have any tips for Mary Lynn?
Well, I mean, there is the term called, non-scale victories. So the NSVs, which you often see, in bariatric peer support groups, etc. They're saying, count your NSVs. What are your non-scale victories? So what has that really changed in your life, and what has gotten better in your life? That's not related to the number that's on the scale. So we've mentioned other things. Jennifer mentioned other things like improvement in energy levels, improvement in stamina, improvement in mood, improvement in social context. So these are all things that are really important to people, and they can improve, and they can improve in a completely weight independent fashion. There are some things that'll only get better if the patient actually loses weight, because that might refer to some of the mechanical problems. Sleep apnea, for example, is unlikely to get much better, unless there's a substantial amount of weight loss. But there are lots of other gains that patients can have, and things that might be much more important to the patient. So if someone has sleep apnea but is on a CPAP machine and is well managed, and doesn't really bother them, they get good sleep, then getting off the CPAP machine might not be a priority. And so, but for that same patient, something else might be much more of a priority, and those are the kind of victories you want to focus on. And those are the kind of victories that I focus on with my patients. So. And you often have to remind people that that they're so much healthier since they started the program than they were when they started. And this is often even though they might have lost very little weight, in the program. because a lot of these goals are achievable with minimal, I would say minimal weight loss or almost no weight loss.
Mhm. Okay. So Lara is just wondering about in your various practices, how you integrate calorie tracking or food tracking into your practice. You know, do you steer away from it, or how do you integrate that into your care?
It's Carlene here. I think with any type of self-monitoring, whether it's self-monitoring blood pressure, blood sugars, mood, energy, exercise, whatever the patient is interested in, maybe getting more awareness about, or looking at using tracking to get some insight into behaviors to look to see what's working, what's been effective, and areas that that might be an opportunity for change. So I think it's really, as clinicians, we need to be quite skilled in looking at many different ways of self-monitoring, because it isn't, I always say it's not dietitian monitoring, it's self-monitoring, is finding out what works for that person to be able to help them to be able to do that. And then recognizing too that not everybody is going to do it at the same level of detail. Not everybody needs that amount of detail. Some people are very much into developing, for example, color-coded spreadsheets and put all of their calories on it. Some people do more like food frequency, food trends. Some people really just kind of take a look at what's going on the weekend because they find their weekdays are quite structured. It's really trying to see what we most helpful for the person at that time.
Mm-hmm. Fantastic, Carlene. Thanks. Anybody else have anything that they want to chime in on that topic for Lara? Okay. Well, then I might pivot to Cheryl and Sanya have related questions. So Cheryl's asking about what you're currently using to measure adiposity. And Sanya's asking whether there's any recommendations on measuring the various components in the body, so muscle versus adipose tissue, to give a bit of a breakdown of components and whether these are accurate to help monitor patients if BMI is not the best indicator. So some just really good practical questions on measurement and how we move away from, you know, BMI as the only measure. Carlene, I know you spent a lot of time in Carla Prado's lab where you spent, where you guys do
Yes.
an awful lot of measurement that we're not going to be doing in the clinic, but maybe you might want to try
Have
to
done
tackle.
an awful lot of measurement in many, many different ways. Yes. So
yeah.
short answer is I actually did a review paper. So it's Johnson, Stocklosa, and Prado. If you can find it on PubMed, about looking at comparing different types of assessment tools to be able to look at accuracy of measurement of body composition and the different tissues within people with BMIs greater than 35. Our subjects were pulled from the Edmonton Adult Bariatric Specialty Clinic. And so that's the context and the subjects there. And what you'll really find is that definitely your home, let's say your home-based scales, what they're doing is basically using like the BIA or bioelectrical impedance technology to try to be able to get that electrical current to be able to measure basically water through the tissues. So it's definitely not an accurate way, especially from a clinical perspective, to be able to do that. We can actually, we're fortunate in Edmonton, we actually have scanners that we can actually have people with a higher weight capacity and higher waist circumference and body size to be able to do DEXA scans to look at accurate for body composition. But for, let's say, a practical access for that is it wouldn't be that practical from having that available to every patient coming in, every clinician. And in addition to, like, I just found as a clinician, how do you then determine once you get that report what you're going to do with it? I think it would be helpful to know if people have low muscle mass versus higher muscle mass, to be able to then target therapies to try to help preserve muscle mass, or actually do like exercise prescription to do therapy to build muscle mass, including with nutrition. I think that's really, really important, because definitely you can't tell just by BMI or waist circumference or a weight on a scale, those components of that body as to whether somebody has a much higher ratio of fat to lean tissue that would actually impair health. And in the research that we did, we actually found that we even had people in their 20s with sarcopenic obesity. It wasn't just people who were older.
It's such a fascinating area with so many implications for drug distribution and all sorts of things. Maybe what we should do, Carlene, is when we send out the email with the recording next week, we should try to add in just a link to the citation of that paper. That's great. Does anybody else have any other thoughts for Cheryl and Sanya on this interesting issue and sort of the implications of that? Carlene, did you want to comment really briefly on the chemotherapeutic drug sort of distribution with the sarcopenic obesity? Because that's, I think, fascinating.
We lost Carlene, or she's on mute.
Yeah.
I'm sorry. That's not. I don't have a lot of any really experience with the chemotherapy medications in obesity.
Yeah.
So I would leave that to someone else to respond to.
Sure. Sorry. Yeah, Arya, did you want to comment on that, or?
Well, not specific to chemotherapy. I mean, obviously, body composition does impact drug distribution, but because it's so unpredictable, and we use a lot of drugs where you can't actually measure the plasma levels, a lot of this is guided by clinical response, right? So, it is an area where there's a need for a lot more research in terms of pharmacokinetics of drugs, of distribution, excretion patterns, etc. I mean, we also have to recognize that in many people with obesity, especially in the elderly, there could be impairments in renal function. There's impairments in hepatic function. I mean, all of those factors can definitely affect bioavailability and pharmacokinetics. So it is a very complex area in which we definitely need a lot more research.
Cool. So Darylene and Rhiannon are going to have the last words here related to primary care. And so Darylyn's wondering about, what would you recommend to primary care providers regarding nutrition interventions and counseling to achieve specific goals for patients if they don't have an access to a registered dietitian, which is sadly the reality in so much of Canada. And for Rhiannon, she's wondering about whether there's any care pathways or protocols for, the need for more urgent weight interventions in primary care, and is sort of citing the challenges with access to care, to referral for tertiary services. So I think those are great questions to wrap up on. Does anybody want to tackle the access issues, both to dietitians and to tertiary care, and what to do in the interim for the primary care providers?
Yeah, I can maybe tackle the access to care, and then maybe I'll pass it over to my other panelists for the other question. But I mean, I think this is a challenge that we see in all chronic disease management across Canada. Dietitians, are not readily available or accessible or affordable. The role of dietitians, similar to other chronic diseases, like I'm reminded of diabetes, and how dietitians have been advocated to be part of a team for diabetes management. And I think we're going to see the same thing with obesity management, that dietitians need to be integrated across primary networks and primary care across Canada. But I do want to emphasize that dietitians are available sometimes even as a free service through provincial telephone or virtual care. And so I was just going to say that's something we might be able to link into the recording, or something we can send out, what's available across Canada for people who may not have access to an individual dietitian, but might have access to at least online support or phone support or something.
That would be awesome. I think everyone would so appreciate that, Jen.
Okay,
And
we,
so,
we
yeah,
need to advocate, obviously. Like, I mean, that's something that Dietitians of Canada is really working towards, trying to get more dietitians accessible everywhere, and that's why we need healthcare professionals to you know, to include dietitians in more of their health care supports.
perfect. Yeah, and so then on the other part of the advocacy question from Rhiannon, you know, increasing access to tertiary level care and how to support patients in the interim while they're waiting for care. Does somebody want to tackle that?
Well, I can take that one. I mean, that's that's an important question, and that certainly happens in primary care a lot, but not just in primary care. I mean, we've got patients waiting for other procedures and other interventions, uh, where they're on waiting list and they're acutely deteriorating, or sometimes procedures are there that just cannot be performed in patients, which is why in Edmonton and the Bariatric Center, we now actually have what we call a pre-surgical weight loss clinic, where the specific goal is actually to get weight loss, even if it's only short-term weight loss, because that can be a benefit to patients who are in these, desperate situations, if you want. But obviously, these are exceptions, and these have to be carefully monitored. The goal here is not long-term obesity management. It's really very much targeted. And for most of these patients, the only way to do this quickly and safely is with the use of formula diets, which is something we haven't talked about today. But is also described and discussed in the guidelines. So these are exceptional situations, exceptional patients, but you have to do what is possible. I mean, ideally, these patients would be referred to tertiary care centers and would be fast tracked for treatment. But we know that in Canada, that's not what happens.
Great. Well, thanks everybody so much for the rich discussion, and Jennifer for the presentation, and all of the group for the work on the chapter. I think it's really helpful to have everything collated in one place, and it's just super to be able to learn from all of you today. So thanks also to all of our attendees for the participation, and we'll liaise with Jennifer and Carlene to get some of those references sent out with the recording next week. And we'll really look forward to seeing you guys for the rest of the series. So thank you so very much. And thanks also to all the team at Obesity Canada and at the Office of Lifelong Learning for all the logistical support of putting these webinars together. So have a great evening, everyone.